Thanks, Glenn. It's a delight to be here to make new friends, but especially to see old friends. The simple way I'd put our relationship is to say I knew Glenn before he was Dr. Mays. So it's great to come to this part of the country, to Kentucky, to visit Doug Scutchfield and other friends here. The honest, real reason that I came, if I can be real transparent with you, is I have a brother who lives about 30 minutes away, and I spent last night in Danville, Kentucky, so I'm happy to add on this occasion at luncheon with you today. You are the experts in the field of public health systems and services research, and I had to ask Glenn to explain to me what the difference is between systems and services. So if I don't get it quite right, somebody will have to correct me. But you're the experts. You're doing it, whether in academic settings or in the practice community or with nonprofit groups or others. And I promise you, I'm not an expert. I think of myself as a longtime supporter of this field, an occasional doer of public health systems and services research, and a longtime user of the results of the research that you are engaged in. But what I am is largely observing this field from the outside and cheering you on, and that's what I hope to do in this short presentation this afternoon. What Scutch asked me to do in his invitation is to give you some personal reflections on my intersection with this field over the last, I hate to say it, but 35 years or so. I used to have more hair, yes, even up there as well as the beard. So what I'm going to do is tell you a series of vignettes, and I state from the outset that they will be personal stories about me. I apologize for the personal references, but you can't tell personal vignettes without talking about yourself. So if anybody is put off by that, get ready, you're about to. I went to medical school at UAB, as Glenn told you, University of Alabama, Birmingham. Birmingham is my hometown. I grew up there. And I believed that when I went to medical school that I was going to emerge 4 years later out the other side wearing a white coat and carrying a stethoscope and seeing patients one at a time. And then in the spring of 1972, so what's that, 41 years ago, next month, we had a guest lecturer come talk to our class who was then the county health director in the urban county around Birmingham. It'd be like the Fayette County Health Department here. Did I do that right? So the Fayette County Health Department, or the Jefferson County Health Department in Kentucky terms. And he talked about public health and population health and childhood immunization and the important concepts of epidemiology and health and disease in a population. And I was just transfixed with that, with this young, charismatic, energetic public health leader whose name is George Hardy, who some of you know. And George really explained this in a very impressive way to me. And I was so taken with it that I went to see him the next day at his office at the county health department and said, I heard your talk yesterday. I've long been interested in public policy and politics and whatever, but I thought I was leaving that aside when I went to medical school. But what you talked about sounds like a way of blending that interest in public affairs with medicine and health and whatever. And so he told me some more and said, if you're really interested in this, take a month in your junior year coming up and spend it with me here at the health department, and you'll learn more. And I did, and I learned a lot, including going to Montgomery, the state capital, with him to lobby the legislature and the governor. And at the end of that, he said, if you're pretty good at this, if you want to do more, why don't you take a month in your senior year, and I'll see if I can help you arrange to go to Washington and work as an intern for a month. And I did that, and I got Potomac fever in a big way. And from then on, have been interested in this broad field that today is called population health, I think, but has gone under different rubrics over the years, public health, whatever else. I matched in the intern resident matching program in pediatrics and went to the University of Colorado in Denver, spent 3 years there. I'm a fully mentored pediatrician, though I've wandered far away from clinical pediatrics, I would attest. But right after I finished my residency, I was able to go back to my hometown, Birmingham, and become the county health director, succeeding George Hardy, who had gone off to work at the CDC. And so at the tender age of 27, I became this public health director. Most people I'd ever supervised were 2 interns and 2 medical students on rounds, and bingo, I was running an agency of several hundred people and millions of dollars in budget, and I had a wonderful time. People were kind to me, or the good Lord was blessing me, however you want to interpret that, but it all worked pretty well. But one of the things that I learned in that process was related to this topic of public health systems and, I guess, public health services research. About a year into the job, the local newspaper did an expose series on our restaurant inspection program. And it was not fun to read because we were operating a pretty bad program, not very well, not very modern, not very well put together. And the editor of the paper came to see me and said, you know, we'll keep doing this and it'll still be painful, or you can give us every week the results of your inspections and we'll publish them in Friday's newspaper. And so beginning in 1978, the Birmingham Post-Herald began doing that. And I learned firsthand how information properly assembled can drive decision-making of consumers and the operators of restaurants, and that's public health services research put to very good public application. During that same period, 78 or 79, I participated with Hugh Tilson and a number of others developing model standards for public health, local public health services, an effort that the CDC and others funded. Some of you probably participated in that. And that public health systems research and work has gone on to fruition. I also went to the CDC in 1979 to a conference that Bill Foege and Mike McGinnis and Martha Katz put together to develop the 1990 Health Objectives for the Nation, Healthy People 1990, which is public health services, public health systems work, and it has gone on to many subsequent editions, lots of important work. In 1981, I was at the University of Alabama, Birmingham, first as a faculty member and then as a student to get my MPH, and I published my thesis, which was a requirement in those days. My thesis was an analysis of the organization and services of local health departments in Alabama. So my colleague, local health directors, helped by filling out a survey instrument that I gave them, and we put this together. And what it showed is, for the most part, in urban settings, public health was sort of well funded, and in rural areas it was terrible, and the organizational structure was fragile and not very well operating, and I think some of those statements still might well be true. But this notion of public health systems research is something that I learned a little bit about as I did it, with a lot of help from fellow students and faculty members at UAB School of Public Health, one of whom was a young public health faculty member named Eli Capilouto. Those of you that are based here at UK know that he's gone on to a career in higher education administration. The following year, 1982, I went to Washington first as a White House fellow, supposedly for a year, and worked on the domestic policy staff that in President Reagan's first term. And after my year, was asked to stay on as a political appointee. I did that for 3 more years, and then was, as you heard from Glenn, sent over to head the agency now called CMS. And right as I arrived, we were presented with yet another public health services a research opportunity, because the New York Times had demanded access to the information we generated on hospitals and mortality rates in hospitals, and we began publishing an annual report on mortality rates with very crude adjustment for the severity of illness of patients across hospitals, and we did it despite the storm of protest from the hospital industry and the physician community and others. We did it because we believed that it would generate a movement towards quality measurement and reporting, a movement that has resulted and still continues. But one of the things that sustained me at the time when I was telling the American Hospital Association and others that we really are going to do this and we want your help to do it better, I thought many times and again told them many times about my experience in Birmingham with the restaurant inspection program, and what I had learned from that turned out to be crudely applicable, of course, to the hospital industry writ large. I went back to the White House after my time at HCFA, now CMS, and was privileged to work for President Bush, the first President Bush, on his domestic policy staff. And in 1989, along with Tom Scully, who was then at the Office of Management and Budget, the two of us worked for the passage of a major piece of domestic legislation that changed the way the Medicare program pays doctors. A complicated health services research project itself to develop a new way of doing this, and an element of that bill that didn't get much notice at the time but has since come to be an important one was the creation of a new agency in the Public Health Service, the Department of Health and Human Services. The Agency for Healthcare Policy and Research was born in 1989. During this period, this field of health services research and public health systems and services research and on has grown and flourished, and I surely would have to note many others who have done important things in this area. In 1990, I went back to my public health roots, was asked to go to Atlanta to head the CDC, and was privileged to work there with Ed Baker and Steve Thacker and Jeff Copeland and a number of other leaders in the field, in our field. Strengthening the nation's public health infrastructure was one of my three objectives that I used to give my stump speech about as I talked about what I wanted to accomplish at the CDC. And shortly after that, Steve Thacker came to me and said, you know, we really do need to create a movement in public health to bring the tools of effectiveness and outcomes research to prevention. And so Steve Thacker and Steve Teutsch and others created the Prevention Effectiveness Initiative at the CDC that has since become an important ongoing part of the work of that agency. They published a book about it that has been widely used in the field. In mid-93, I left the government. As somebody was reminding me today, I got the privilege to go join the private sector by President Clinton, who helped me leave the federal government. Only a few people got that, but that was a joke. So I left the government in '93 and went to the private sector to start the Prudential Center for Healthcare Research with my friend Jeff Copeland, who came with me from the CDC. And I got involved with the Association for Health Services Research, now known as Academy Health, and Lisa and I had the chance to visit a little bit earlier today about that. But one of my early memories of that period was I was on the board of PHSSR, again that's now Academy Health, and another of the board members, John Eisenberg, who was then the chair of medicine at Georgetown University. Eisenberg and I were sort of a two-person task force to figure out what should be done with this still relatively new agency in the public health service, AHCPR, because it was underfunded and didn't get the respect that it needed, and the question on the table was, should it be folded into NIH, and might it enjoy greater funding and stature and whatever at the NIH? And Lisa was telling me some of those same questions are getting raised again and again today. John Eisenberg, of course, went on to head that agency, and with help from Senator Bill Frist of Tennessee, renamed it the Agency for Healthcare Research and Quality, got a lot more money for it and increased stature for it. John tragically passed several years after that. But in 1997, I was recruited to academia and to the University of North Carolina and worked for Glenn Mays. That was a joke, but it's really true because it was such a privilege to work with him. During that period, this field flourished because a lot of people in federal agencies and in the Congress and in academic settings and in the practice community came to realize the value of doing work in the research area on public health systems and services. I was elected to the board of the Robert Wood Johnson Foundation in 2000 and served on that board for 10 years and got to work with Risa Lavisa-Mori and John Lumpkin and Jim Marks and others. The Johnson Foundation has done a huge amount of work to move this field forward and still does a lot of funding of you and others in your important work in the field. As you heard, about 9 years ago, I moved across Columbia Street, which is our street in Chapel Hill that divides our School of Public Health from our medical school, and have been privileged there to work in our med school and our healthcare system. And actually have a pretty busy day job like my friend Michael Karp, who's here from the University of Kentucky. Mike, thank you for coming. And so I freely say that I'm head down, full speed ahead, working on my day job, and I'm not much involved in these things that you're doing so successfully. But I do read the newspaper, and my friend from a number of connections, Nancy Ann DeParle, who was at HCFA and then in a variety of other roles, went to work in President Obama's White House, and with his leadership and her hard work resulted in the Affordable Care Act that we are working as a nation now to fully implement. Challenges yet ahead, but one of the provisions of that bill was the creation of the Patient-Centered Outcomes Research Institute, and I know Joe Selby was here yesterday talking about that institute and its important work. But I would just say, again, I'm fully preoccupied with my work at UNC Medicine and Healthcare these days, not only trying to survive, but even to thrive in a pretty chaotic healthcare environment these days. The point of all that, if you will indulge me further, is not just a personal set of reminiscences, but to talk about how all these connections have seemed to one participant, one observer across the last several years. You know a part of that because you've lived it, you've experienced it as you have done this important work with the various leading institutions, the CDC, the Robert Wood Johnson Foundation, AHRQ, Academy Health, PCORI, the Association of Schools of Public Health, the Association of American Medical Colleges, the Centers for Medicare and Medicaid Services, and many, many others. I've tried in telling these stories to mention a number of the pioneers that I've been privileged to work with and to learn from. I apologize to those whose names I didn't mention because I've forgotten some people along the way, and I truly, seriously apologize if I've left key figures out of this story. But I'd try to draw this to closure with a few other comments to say, first, where are we now and what does the future hold? And I'd illustrate it with a story, if I could, a further story. In about 1987, after we had launched at the Healthcare Financing Administration what we called the HCFA Effectiveness Initiative, which was an attempt to use Medicare dollars to do what we now know as outcomes research, to learn how better to serve the Medicare population and inform the decisions that doctors daily make for their patients. And I had the chance many times in that period to testify in front of the Congress and talk about this thing. And I recall one day that a representative said in the follow-up question, he said, "Okay, Dr. Roper, I understand what you're saying, and that sounds like it's important, but tell me, when will this be done?" And I said, sir, I appreciate the question, but this will never be done. This is not a project that has a start date and an end date and whatever. This is a continuous process of learning about what it is we do and how we can do it better and do it with better outcomes and do it more cost effectively. And it's a continually renewing process. So that's part of the excitement of this field, but it's also one of the challenges of the field, because the people who appropriate the dollars, whether at the state level or the federal level, tend to have pretty short time horizons, and they don't like the notion of permanent funding for anything. Just to make that point, here in North Carolina, we've been blessed with an annual appropriation from our legislature to do cancer research. And the other day, one of the chairs of the Appropriations Committee in our legislature asked me, how long do you need this? And I said, I'll be happy to stake it. When we cure cancer, then we'll no longer need this. So it's a similar point, if you'll understand it. But it seems to me the two key issues for the field are the funding for public health systems and services research, whether public or private funding, and then applying the results of this work to decision-making in the practical world of public health. And you're engaged, you're involved in all of those things. We're in a time of scarce resources, and every indication I have is that as far as I can see, money's going to be tight. This is not just a temporary period that we're passing through. But the need to apply the results of the work that you and others are doing is more important than it ever has been, and the challenges and the opportunities abound to do that. But I think we need to continually remind ourselves that we stand on the shoulders of those who've gone before, and there's opportunity out in the future. Let me just close with telling you another little story. Shortly after I left the CDC 20 years ago in 1993, they invited me to come back to give the annual big lecture at the agency called the Joseph Mountain Lecture. And in October of '93, I gave a talk that I called Science, Politics, and Public Health. And I pulled out of a box in my office a few days ago a copy of that talk and read it. And so I'd like to share with you a few thoughts from that talk, because they seem to me to be relevant. As I said that day, there's a notion on the part of scientists that politics is dirty, and there's a notion on the part of politicians that science, by its continual equivocations and qualifications, is, if not irrelevant, then it's at least out of touch with practical reality. And I think we have to deal with both sides of that mutual distrust. I believe that the supposed bright line distinction between science and politics that some seem to wish for is really quite fuzzy. There's not a bright line there. I believe that those who assert that we should get politics out of science or out of public health simply don't understand either field. Within our public health system, we need both science to discover new knowledge in a rigorous and systematic fashion to guide policy formulation and implementation, and we need the political process, which is to make government decisions and to implement those decisions through programs. The real question in this area is, how do we ensure that politics is science-driven rather than science being controlled by politics? I continue to believe that the best way for us all to answer that question is to start with the best of science, including public health systems and services research, and stick to it. We shouldn't insert a political filter into the scientific process, either our own political filter or someone else's political filter. And while celebrating science and all that it has and will give us, I believe we need to be careful about asserting that, quote, science equals truth. It surely doesn't, Glenn, I'm going to need some water, excuse me. It surely doesn't equal certainty. Science surely doesn't equal certainty much of the time, and the scientific process invites further inquiry and modification. And while we await the results, we need to press ahead with our collective prudential judgments. Far from being a dark or negative force in our society, politics is the great engine of democracy, the force that fashions our visions for the public good into specific mechanisms that make those visions a reality for our citizens. And so it's my earnest belief that if we as public health scientists were only to do politics, we would fail in our superficiality. For we depend on the best of science to guide our every action, and furthermore, most of us are not very good at politics. But it's also my conviction that if we do only science, our work will not have the impact that it should. It'll be isolated from practical application. So, as I said 20 years ago and say again today, we should carefully blend the two, science and politics, understanding the legitimate voice of the people in a democracy, appreciating and dealing with all the facets of our culture, especially our own individual culture, continually balancing the rights of the individual with the well-being of the community, and then we will have a profound impact for the betterment of the public health. Thank you all very much.